Thank you, everybody. I guess this will be recorded so that way people who miss it can join in. So I'll go through everything, but let's make this interactive. And please, if you have questions or have suggestions as we go through this, stop me. This is totally informal. This is the areas we're going to touch on, kind of a introduction to POCUS. We're going to talk about basic echocardiography, IVC assessment, and lung ultrasound. This is kind of what we focus on in our residence primarily. I do teach an elective too, and we do a little bit more advanced imaging, abdominal structures and such, if residents are interested. So obviously these handheld devices here have really made it, have put it into our hands. As we mentioned, several of the units, the Lumify, the Butterfly IQ. I just got my hands on one called Cosmos, which is a cool little unit that Dr. Gigi Lu tuned me into. So we're looking to purchase a couple of those for our program. So these handheld devices in no way replace the stethoscope, and that's not what I meant by showing this picture, but they really enhance our physical examination. And that's what ultimately ultrasound does. It enhances our physical exam assessment. As many of you know, it just takes it up a notch and really increases the sensitivity of our exam. And certainly the literature is bearing this out, that there's enhancement of our physical examination by using ultrasound. And here's just comparison of the sensitivity via chest x-ray, let alone our physical exam. We know if we find a physical exam feature, that's fantastic. But unfortunately, if you look at the likelihood ratios for finding an S3 among physicians, it's a huge confidence interval there. And that's just because just of so much variation and experience and technique and such, it varies. Ultrasound kind of limits that variation in a way that makes it more better to assess patients at the point of care. So certainly this type of new skill does take time to learn the basics. And this is kind of where we're at with this lecture. Image acquisition, this takes practice and practice and practice, and ultimately being expert at acquiring images. It does take time and integration into your regular exam. Just a little bit about the physics of ultrasound. We're actually talking about sound waves per second is called a hertz, and the amount of cycles per second is defined as that hertz. And for medical imaging, we're in the ultrasound era. Anything above human hearing is going to be called ultrasound. And we're in that 2 to 10 megahertz range for medical imaging. And these are the three main probes that I know many of you are familiar with: the phased array, which is the internist's favorite, the curved linear, which is the ER doc's favorite for their fast exams and such. They get such a nice broad footprint. They can see everything in the abdomen very well. And then there's the high frequency linear probe, which is great for soft tissue, great to do those thyroid assessments, great for assessing the IJ or other large vessels. But really, you're not going to get much beyond 6 centimeters down with the high frequency probe. We love to use it. It's really changed the assessment of cellulitis, handheld ultrasound, and that's all using the high frequency probe. As electrical signals come down, these lithium ion crystals or other technology too create an echo, and really the device is waiting for those echoes to return, at which time the ion crystals will wiggle again and send information back up electronically to the computer, where it creates that wonderful image. And certainly ultrasound can be intimidating for a lot of us. There's a lot of bells and whistles. Really, I tell residents only two main features you need to be aware of and familiar with on any device, and that's really depth and gain. How do you adjust depth and gain? It's a little different on every device, but not hard. Gain essentially is your brightness. So increasing gain increases brightness, decreasing gain decreases it. And of course, depth. I always say these devices we use, where it's the Butterfly IQ or the V-Scan or the Lumify, they're dummy proof, really. You set to what you want to look at. If you want to look at the cardiac features, it'll set the computer marker for you. It'll set the depth for you. It'll set the frequency for you. And certainly, usually it's 14 centimeters, but if you have a very big person, you're going to need to go deeper. If you're a very thin person, you're going to need to go shallower. So I always say the depth is something I would encourage to play with. It can give you such a broad assessment of things. If you don't know what you're looking at, try backing out quite a bit. That usually is the way to go first. I tell residents, avoid gain. Gain can really affect the way we interpret images, whereas dark things should say dark and light features should say light. So adjusting gain, I would do as one of my last movements to enhance imaging. With ultrasound comes this knowledge of orientation, and not to make it complex or anything along those lines, but there is a computer marker and there's a probe marker. And I got a little probe here. I don't know if you can see me, but I got a little handheld thing here that has a marker on the probe. And the computer has a marker, and these need to be in concert so that way orientation is maintained. Anything in the radiology world, whether it's thyroid or abdominal imaging, the computer marker by convention is on the left side of the screen. And anything in echocardiography world is on the right side of the screen. And why is that? Well, the cardiologists just decided to do that many years ago when they discovered and developed echocardiography. The computer marker they placed on the right side of the screen. So that's where a little confusion comes in. Everything else in the ultrasound world, the computer marker is on the left side of the screen. Not a terribly important thing to really get caught up with, but because like I said, when you set your machine, these smart machines will set these points for us. A few things will make it successful. I tell this to my residents all the time. Really, three things primarily. I always say the number one enemy of ultrasound is air. So if there's any air between the skin surface here or your probe, it's going to affect the quality of your image. So using the couple sense gel is so important, as that medium is needed for these ultrasound beams to get through and avoid any air contact. It's amazing, you know, these handheld devices are thousands of dollars, but that little 10-cent gel, nothing's going to work without that gel. So we need gel. We don't want to over gel, but we want to use enough gel to make sure air is not in the picture. And then we have orientation here. So as we're imaging certain structures beneath the skin, if they're at axes such as the heart, I don't know if you can see me here, but if I'm doing a 4-chamber view of the heart, I want to be in line with the heart underneath the skin. And if I'm off, I'll obviously lose those valuable ultrasound beams and my image quality will go down. So thinking about what we're imaging underneath the surface, lining up our probe on the skin surface to optimize the image is key. And the last thing, the third thing, is compression. And most patients can tolerate a fair amount of pressure on the chest. I always tell patients, please let me know if I'm pressing too hard. I back off, but that compression really does enhance the image. One of the things I learned early on when I just was not getting great images, and one of the standardized patients, he kind of pushed my arm down to see how much pressure the instructor was doing compared to what I was doing. And I quickly realized that, gosh, I was not applying much pressure. We don't want to hurt our patients by any means, but that compression does help enhance that image. So very important that we describe what we're seeing on the image computer screen. And these are various shades of gray that we see typically. The hyperechoic structures are typically the most dense, and everyone says, well, that's bone, and that's true. Bone is definitely hyperechoic, avidly absorbs ultrasound beams, gives a very bright signal. Whereas other structures, such as the diaphragm listed here, this is a coronal shot. I don't know if you can see me, but this is a coronal shot on the side, probe marker to the head. So I know the patient's head is here and the feet are here. This structure happens to be the liver, and this hyperechoic structure is the diaphragm. And it's not a bone, but it is a very thick line tissue. So not only bone, but diaphragm, pericardium, pleura, all these thick tissues will become hyperechoic on ultrasound. Anechoic. Anechoic means devoid of echoes. There are no echoes. And a good example of that is liquid. And that would be liquid of any kind. That could be pus, blood, urine, you name it. That is anechoic. So ultrasound beams love liquids. They just dive right through and they swim until they hit a solid structure, and then they get reverberated back. So anechoic is devoid of echoes. Sometimes people say this is air. It's not air. This is liquids. Air looks like anything, really. So air will look like a fuzzy mess. So if you're in the abdomen and there's a lot of bowel gas, sometimes it'll be bright, often it'll be grayed out, because you can't predict where those ultrasound beams are going once they hit air. And it really does not create a pretty image. Isoechoic is the liver, and this is the liver here, and we usually say the liver is the most isoechoic organ, and we compare other structures to the liver. And hypoechoic is between the isoechoic and anechoic shadings, and this is the kidney here, and this is kind of demonstrating in the kidney cortex that hypoechoic. In the inner pelvis of the kidney, it's bright, and that's because there's a lot of fat in the renal pelvis, and that gives us a little bit more hyperechoic picture. When we talk about ultrasound, we talk about probe movements, and really I try to get my residents to really understand these probe movements. They are very important. These are accepted terminology that we really use throughout point of care ultrasound. So that way, if they're doing something on the chest, I can tell them which way to move and they can follow my instruction. So these are translational movements, and there's 3 of them. Every probe has a long, if you can see mine, has a long axis and a short axis. Long axis and short axis. You can even use your cell phone as that as well. There's a long axis and a short axis. So if I'm moving along that long axis in a transitional plane, that's called a slide. If I'm moving along that short axis, that's called a sweep. So if I'm doing a parasternal long axis of the heart and I say, move, if I sweep up to get into a different intercostal space, or if I see that I'm seeing a lot of aorta and I know they're very close to the sternum, I'll say slide to the patient's left to come off that sternum so you can see a little bit more, get a little bit more picture of the chambers. That is a slide. So there's slides and sweeps. And the last one is a compression straight down into the patient. And then there's the rotational movements. And likewise, they're along the long and the short axis. If I'm along the long axis, it's called a rock. And this is a good example in the short axis. When I'm looking at the heart, often I'll do a rock to swing that perfect circle in the center of the screen just by doing a rock. And also on that short axis, the tilting and the fanning kind of moves along the short axis of the probe, looking at different areas of the heart. So that this is a rock, and this is a fan or tilt, as we call fan or tilt. And then there's rotation, clockwise or counterclockwise. So those are 6 total movements, 3 translational and 3 rotational movements of the probe. I try to get residents to kind of speak in those terms, but often when you get away from it for a while, you tend to forget. So getting back to a little on orientation, when we're in the abdomen or really anywhere in the body, the probe marker points to the patient's head. You can see this is a sagittal or longitudinal section through the abdomen of this patient. Here is the computer marker, because we're in the traditional radiology world. The computer marker is on the left side of the screen. Probe marker points to the patient's head. And that will be true no matter where you are in the abdomen. If you're doing thyroid or other structures that's in radiology world in a sagittal or longitudinal plane, the probe marker typically will go to the patient's head. That way, if I'm looking at the screen, I know the patient's head is here and the feet are here. And obviously, I wouldn't see that on the screen, but you would know that when you're scanning the patient. But sometimes when you're looking back, you may forget. So that's why it's important to keep that orientation. If we're doing a transverse cut, just like in CT scan, you would take the probe marker and point it to the patient's right. So in the abdomen, the probe marker goes to the patient's right in a transverse section. So that way I know on the screen, this is the patient's right side, this is the patient's left. If I see 2 tubes, I know the tube on the right is the IVC and the tube on the left is the aorta that overlies the spine. So this is helpful. So in the abdomen, again, if you're doing a transverse longitudinal cut, probe marker to the head. If you're doing a transverse cut, it's to the patient's right. So sagittal, longitudinal, patient's head, transverse to the patient's right. And then the coronal shot on the side, probe marker to the head. So essentially it's pretty easy. We're either going to the patient's head or to the right side of the body, depending on what slice we're looking for. So if there's any questions, just stop me, because I tend to talk fast. And then we have some cases at the end that kind of bring us all together. Echocardiography is where we'll start, and basic echocardiography. These are the 3 main points of access to the heart. Whether you're here or halfway around the world, these are consistent everywhere you go. And this is the parasternal area. We like the parasternal area the best because why? There's a break in the lung and we get a clear shot at the heart typically. I always start high, your 2nd or 4th intercostal space, and I make my way down slowly. Why is that? Your better quality image is always the higher you can go. So I tend to start just parasternal, make some sweeps, bringing the probe down. I didn't talk about how do you hold the probe, and that is very important. The probe should be held in scanning for parasternal long and short axis, kind of like a pencil or pen. Your finer movements are going to be done with your 3 fingers, and I like to plant myself down. It's hard for me to do it with this particular probe, but I like to plant my hypothenar eminence on the chest once I get a good position. So once I scrolling down this parasternal area, I see something moving, I plant myself down, the hypothenar eminence goes down, and all those translational and rotational movements I talked about are all done with these 3 fingers. Literally what comes out of this ultrasound is a thin layer of ultrasound beads. So you can imagine if you make a big sweep or if you make a big slide, you're going to totally change that image on the screen drastically. And we don't want to do that necessarily. So we want to make small movements of the hand. And that's where the practice really comes in, is how do you fine tune your hand-eye coordination? So that's the parasternal, the apical 4-chamber. We're not going to talk about today. A little bit more advanced imaging, you have to go through the lung, but we can talk about that. There's some interest there. And the subcostal shot, which I think is equally important, which I'll get to in a moment. So we're going to start with the parasternal long axis. And it's always hard for anybody to take a 3D image and go to a 2D screen image. So I do have 3D models that are fun to play with. I give to the residents to kind of, again, get that feel of that 3D to 2D structure. So essentially, we're taking a slice through this 3D image, and this is what we're going to see in the long axis. So simply put, we have the patient lying supine, and we're going to again start third intercostal space. We're going to march down just off to the sternum, onto the patient's right side, the patient's left, and we're going to point our probe to the 10 o'clock position, or the right shoulder. This is the only move in echocardiography that points to the right shoulder. Everything else goes to the patient's left. So it's easy to remember. Parasternal long axis is our favorite. We get the most information probably in point of care ultrasound from this view. Simple, start high and work your way down. In our hyperventilated patients, as we age, everything seems to sag. So I say go where the image is. So you keep going down rib notch by rib space, down, down, down until you acquire your image. It's different on every patient. But if you start higher, that's how you get your better quality image. So one of these images is correct. One of them is incorrect. Take a moment to kind of look at those two and think which is the one correct image, which is the wrong image. And this gets back to where the computer marker goes. Remember, in everything radiology world, the computer marker's on the left side, but in echo world, the computer marker's on the right side of the screen. So this is the correct image for echocardiography and parasternal long axis. This is the incorrect image, but you can certainly see structures here as well. But if you took this image and showed your friendly cardiologist, they would think you're a little crazy and they would not be too happy with that. But if you showed them this, they would get a big, bright smile. And they would help you with that image interpretation. So here is what's happening as ultrasound beams are diving through, hitting certain parts of the heart, bouncing back up to through the probe and into the computer and creating the image for us. The right ventricle is always on top. Why is that? It's the most anterior structure of the heart. So we're scanning through the skin, and then we hit the right ventricular wall. We call this the right ventricular outflow tract. Some people refer to it as the right ventricle, but really it's the right ventricular outflow tract here. Then we dive and hit the septum listed here, and that's pictured here. The aorta is here, the aortic valve. The left ventricular outflow tract is here, a very important area. They have the LV cavity. We have the posterior wall. We have the pericardium, the very bright pericardium, it's hyperechoic. And we have the three chambers that line up quite nicely. Again, let's name these structures. This is the left atrium seen here, the aorta, and the right ventricular outflow. These three chambers should line up fairly nicely. You'll notice we have the mitral valve. The anterior leaflet is the larger of the leaflets, and that sits up top, and the posterior leaflet sits down here. You will notice you only see 2/3 of the LV, and this is normal. You should not see the apex. So if you're seeing the apex, you are what we call off axis, and that gets the fine tuning. And that's really when you get to ultrasound 102, where really we optimize our image. And this is where Gigi Liu is our expert at, and she is fantastic at helping us optimize images. And the parasternal long axis, I will tell you, it is important. It's probably one of the easier views to get on axis. And there's a few main things to keep in mind. We want that anterior leaflet to be right centered with our screen. So here's our probe. We're coming straight down. That anterior leaflet should be dead center. That's number one. Number two, what we see of the LV cavity should be nice and wide, as wide open as you can. And there's techniques to increase that. That's just by rotation. I usually start, remember we're at the 10 o'clock position. I'll do a counterclockwise to see if I can open up the LV cavity. If it gets smaller, I come back and then I'll go a little bit clockwise until I find the perfect LV cavity that's as wide as I can get it. That's what we're looking for, the widest LV cavity with the anterior leaflet centered. And then our last thing is looking at the septum, and we like a nice flat septum. I'm going to show you some examples in a minute. So I'm going to start with a quick video. I apologize, this quality is not great. It's one of my V-scan images early on. As you can see, when I started doing this in 2016, I've just been too lazy to update it. I do have some updated images, but be that as it may, you should be able to quickly determine the patient's ejection fraction from this. And when we talk about ejection fraction in point of care ultrasound, we don't talk about percentages. We talk about normal, mild, moderate, or severe. So we talk about general categories. Everything in point of care ultrasound is kind of an eyeball. So we're getting an eyeball estimation of a patient's overall ejection fraction. So that is the first thing that we should, well, that's probably the second thing we should notice. The first thing we should notice is our chambers. So we should have our chambers lined up nicely. We have the right ventricular outflow, the aorta, the left atrium. Here's our septum. Here's our LV cavity. Remember, we're not seeing the apex, which is good. We're only seeing 2/3 of the LV cavity. Here's our anterior leaflet of the mitral valve. And here's our posterior leaflet. Down here, you can kind of see the descending part of the descending aorta. I probably should have gone even a little deeper for this shot. Anybody have any comments? If you would care to guess on this patient's ejection fraction and other things you may see on this image.
You'd be okay, normal.
Normal, yeah, good. So that's quite all right. And so hopefully by the end of this lecture, and the basic echocardiography, I want everybody to recognize that this would not necessarily be a normal EF. In fact, this patient had a EF at 10%, believe it or not. So I'm going to walk you through how do we determine the patient's ejection fraction at the point of care very quickly, very easily, and what are these structures telling us? So let's walk through this patient. So we have
Dr. Weissman,
yeah.
really
Please interrupt me at any time.
I'm looking, as I examine the patient, I'm sort of as the patient's lying, let's say, on a table, I'm to the right and I'm palpating the apex, with my hand.
Yes.
I just thought everything would be just the opposite way. The apex it would be on the other side, but I guess I'm missing.
Yes.
So.
Yes, and I think that you would be right. If we were in the standard radiological mode, where the computer marker would be on the left side of the screen here, you would be right, and that would be. And if I went back to that previous image,
yeah,
here's where you would probably say, "Yeah, I get it. This is making sense to me." And this is where echocardiography gets a little confusing, and it's just taking a step back and think, God, not only am I slicing a 3D image and making it a 2D image, I'm flipping it with what the cardiologist decided to do by putting that computer marker on the right. So the image gets flipped.
All right, okay.
And that becomes exceedingly confusing. Yes, and it takes time and practice and looking at these images. And trust me, there's loads and loads of images.
Okay.
And I'm gonna give you some good links at the end too to kind of refer to. But you're absolutely right. So when we first look at this, and this is will be a standard echo image in the parasternal long axis. Left atrium is here, and normal size is important. Now, pretty much anything in the vascular world, 2 centimeters tends to be the normal vascular structure, whether you're your IVC, whether your left atrium, your right ventricular outflow, your aorta. If you think about it, everything should be about 2 centimeters. We know all roads that lead to badness lead to left atrial enlargement, right? So left atrial enlargement is indicative of high end diastolic filling pressures of the left ventricle. That poor left atrium has had to put up with this for years, and as a result has had to grow in size to compensate for high end diastolic filling pressures. So left atrial enlargement is an exquisite sign for badness. And we know I certainly want my left atrial size to be 3 centimeters. The upper limit is considered to be 4 centimeters of normal, but a lot of evidence is pointing towards in that 3 to 3.5 is when things start to go sour. So measuring left atrial size is easy. We can take our centimeter markings here. We got 1, 2, 3, 4. It's about a 5 centimeter left atrium. So that tells us something. That tells us this patient has chronically high end diastolic filling pressures. You can almost use left atrial enlargement as a surrogate for heart failure. It doesn't tell you if this patient has preserved ejection fraction or reduced ejection fraction, but it does tell you this patient likely has heart failure. Although I would say that's not the only reason that causes left atrial enlargement. By far and away, that's the most common. Certainly valvular issues would cause left atrial enlargement as well. Keep these in mind, especially mitral valve stenosis. And likewise, if we come see aorta and it looks abnormally large, that will give us information. If the patient comes in short of breath and we see a very large right ventricular outflow, that may give us a clue that something on the right side of the heart is going wrong. So each one of these chambers is valuable. We call it the rules of 3. And again, they should be about 2 centimeters each chamber. Again, even the right ventricular outflow is generous. So this patient likely has biventricular high volumes, high failure, I would probably say. I can give a great example. One of my residents, when they went out to assess a patient in the ICU who was obtunded on the ventilator, the team asked him to go in and look for the volume status and doing an IVC assessment. He first started the parasternal long axis. This patient came in overnight and he noticed a very large aorta. And as so happened, the echo tech was coming in at the same time. They looked together. And so it happened that the patient had a dissection that they could see on echocardiography, and a huge aortic dilation. And the patient, in fact, had aortic dissection. Patient was obtunded on a ventilator and was not able to complain of any discomfort or pain. The patient was later transferred for that reason and saved. So all these chambers give you valuable bits and pieces of information. So remember, 2 centimeters each size. So that's the first thing my eye keys on is the chamber sizes. And then I'm going to answer the question about left ventricular function. And there's 3 main signs. 2 of them are in systole and 1 is in diastole of LV strength or over LV ejection fraction. And so the 2 that are in systole are myocardial thickening. So during systole, the myocardium should thicken, and it should thicken by 25, 30%. It should be an obvious thickening. And here, if you see the walls are moving, but they're not really thickening in size. I'm going to give you some examples in a minute of showing really clear thickening. Likewise, the posterior wall here is not thickening. And then there should be endomyocardial excursion. So during systole, to pump out that normal EF of 60%, the walls have to come together. And I should be able to put my finger here, and those walls should just about come to my finger. Well, none of that is happening with this particular patient. So we're not seeing any myocardial thickening during systole. We're not seeing endomyocardial excursion during systole. So that gives us a clue. And the diastolic component is what we call the SLAP sign, or E-point septal separation, the more technical term. So if you're a good, healthy LV, you want nothing more than to pump blood around this body. And so during a squeeze and you relax, you want to fill up with blood, and that nice elastic recoil should snap open that mitral valve during diastole, and it should really almost slap the septum. We say technically it should come within 7 millimeters. I tell residents, if it doesn't come within a centimeter, well, that's a good clue. You probably have reduced LV function. And you see this patient's anterior leaflet is a big gap between the septum and where the anterior leaflet ends up opening during diastole. So this particular sign, called the SLAP sign, is highly reproducible by multiple different observers, and you can clearly see that there's an issue here. I'm going to show you an example in a minute of there are a few limitations of these 3 signs. In general, I always say, always complement your EF with another view. So never just make one determination of a patient's ejection fraction based on one view. We want to collaborate it with a second view. I'm going to go on to a few more examples. This one's a little bit more obvious, perhaps, of a low ejection fraction. Again, let's look at some signs. So here is the 3 chambers. We're getting a little bit what we call an edge artifact here. That is common, and I'll show you some examples of that. And unfortunately, it's a reflection off the aorta here that creates a false sense of the left atrial wall. So the left atrial wall is really here. So trust me, that is an enlarged left atrium, quite enlarged. But let's look for a minute at the function of the heart. So again, myocardial thickening, not a whole lot. Endomyocardial excursion. Well, again, I put my finger here. There's not much movement towards my finger. And then that E-point septal separation, or SLAP sign, the anterior leaflet is far from. So I would call this patient severe LV dysfunction. So another good example, here's the patient's descending aorta, which I do like to see typically in that view. Compare this to this particular patient. I'm going to run this through quicker because in the interest of time. Here's the patient's left atrium, aorta, right ventricular outflow. You can see here the left atrial size is really huge. I'm at 18 centimeters. I'm going to measure it. 1, 2, 3, 4, 5, 6. It's about a 6 centimeter, maybe a little bigger, left atrium. Just massive, massive left atrium. So we know this poor left atrium has been under a lot of stress for a long time to get that big. Also, the right ventricular outflow is very generous. So again, a patient with an example of biventricular failure, really. Aortic size is probably where the chamber sizes should be, around here. And then we're going to look at the myocardial thickening. Again, these are not the best images using some of my V scans. I'm going to show you some better images in a minute. Is there myocardial thickening? His heart's so big, it's hard to get we probably should have had a little bit more viewing here to see myocardial thickening. How about endomyocardial excursion? Well, again, hard to tell. I can tell here that the cavity is small. It's a small cavity as compared to this big dilated cavity. And you can see the anterior leaflet is coming quite close to hitting the septum. So if I slowed it down, which I could do on the actual machine, we would find that it would come just about to the septum. So this patient has evidence of heart failure with preserved ejection fraction. So this ejection fraction preserved, this is a classic example of someone long-standing hypertension with a very thick LV wall, small cavity, huge left atrium, two extreme examples. So this would be left ventricular heart failure with reduced ejection fraction, heart failure with preserved ejection fraction. And finally, we'll look at a normal patient's EF. We have the 3 chambers here, all about the right size. Let's look at myocardial thickening. Clear myocardial thickening happening here. Endomyocardial excursion. The LV cavity is shrinking. It's coming towards my finger. And that E-point septal separation, you can clearly see the anterior leaflet hitting that septum quite nicely. This is a little bit clear image using a different instrument called the Lumify. You can see the difference in quality. All these are handheld devices I'm showing you today for the most part. Here's the patient's left atrium, aorta, RVOT, the septum. Again, let's look at myocardial thickening. Yep, I see the myocardial thickening and the myocardial excursion. Yep, coming in towards my finger. E-point, septal separation, slap sign. Yep, looks good. So these are the 3 signs of ejection fraction in parasternal long axis view. This is using that Vitamex that I talked about with the simulated ultrasound. RVOT, aorta, I like to keep naming structures. Normally I have you guys name structures, but in the interest of time, I think I'll just I think repetition is important here. Right ventricular outflow, aorta, left atrium, aortic valve, septum. Here is the anterior leaflet looks like a leg. It's kicking. It should kick and almost slap that septum every time. Here you can see the myocardial thickening, the endomyocardial excursion. It's coming towards my finger quite nicely. Again, and again, it's all eyeball. Is this thickening by 25% or more? Yes, I would say that's true. And again, that slap sign is there. So this is a good EF. So let's review. We had the rules of 3. We had the right ventricular outflow, the aorta, the left atrium, all should measure 2 centimeters. Patient comes in with symptoms and one of these chambers is abnormal. It's going to point us in one direction. And we talked about 3 signs of overall LV function in the parasternal long axis. 2 are in systole, endomyocardial excursion, myocardial thickening. And the last one during diastole is the movement of the anterior leaflet of the mitral valve. And just to show you some likelihood ratios that surround this is just E-point septal separation, so if you look at the likelihood ratios, and I didn't show confidence intervals here, but this is much more reproducible than even the S3 in between observers. There are some pitfalls of the E-point septal separation. If the patient has severe mitral stenosis, well, yeah, the mitral valve may not open well. Now, severe mitral stenosis is uncommon, and once you see one, you'll typically be able to pick that up. The valve looks very abnormal. The valves almost look stuck together. Usually, typically very obvious. If you have severe aortic insufficiency and the aortic valve is very incompetent and you're blowing down a lot of blood back into the LV cavity, that may prevent the anterior leaflet from opening as it should. And that could cause you to misinterpret. Well, there's an easy way to look for this. We could either in this view put some color flow Doppler, and that's a more advanced technique and interpretation, which is in the 102 course, how to use color flow, but it's really not hard. And there's in other vantage points at different views that we can easily look at for aortic insufficiency. In fact, I've almost given up my stethoscope when I'm thinking about aortic insufficiency. If it's not obvious, I probably won't pick it up with my stethoscope, but I can pick up even mild aortic insufficiency pretty easily with my handheld device. And acute ischemia, and this really gets to the point of Takotsubu's cardiomyopathy or the stress-induced cardiomyopathy, where, as you know, you get apical ballooning of the apex, and we don't see the apex as we should not on this parasternal view, but the base of the heart in stress-induced cardiomyopathy is normal. And so you may interpret that the patient's overall LV function is normal when in fact it is not. We just don't see the apex, and that's why it is important to conclude your overall EF with the other views of the heart. Just to kind of go through some final examples, this is an example of normal. We have the 3 chamber sizes look good. Again, myocardial thickening and the myocardial excursions, a little undergained here, so it's hard to see. But you can easily see that slop sign is looking good. And then here's an example of reduced EF. Again, here's that edge artifact that we talked about. So here's the actual left atrial wall. And the edge artifact, again, is a artifact that occurs in ultrasound where it's a reflection off the aortic wall here, and it causes this reflection. It happens occasionally, but after a while, you kind of you get used to it. You had this funny line that goes up that way, that's an edge artifact. And then this patient's, endomyocardial excursion, not so good. Myocardial thickening, not 25%. And clearly E-point septal separation is down. So this patient would probably be mild to moderate reduction in EF. And this is called the hyperdynamic LV. We actually get the two walls of the ventricle. They come together. We call it the kissing ventricle. And this is your sick patient in the ICU who's on pressors. The LV is trying to make up for a lot of badness in the body, and it's beyond its Starling curve. And this is the hyperdynamic LV. And stop me again if you have any questions as we go.
Dr. Weissman, while you're there, why can't you measure the aortic root dimension?
Oh, absolutely. You certainly could. You certainly could. You can measure the aortic root dimension.
Is that the harbinger of aortic dilatation and
yes. Yeah, absolutely. And as your eye gets better, you start to, you look at there's so much here to really talk about. In fact, I'm going to give you some of the case examples at the end that really start to, as your eye gets better at looking for things, and it's good to be systematic. That's number one. And look at your chambers and make sure all chambers are equal. As we talked about, exactly, the aorta is exceedingly important to take a close eye on. The aortic valve is here for you, and often you can make a diagnosis of aortic. Technically, we need SpectraDoppler to make the diagnosis of aortic stenosis. I mean, we do need SpectraDoppler. That's when we measure velocities of blood over an orifice. We can do that in point-of-care ultrasound. Most of the point-of-care machines don't quite do SpectraDoppler. Some of the newer ones are, and this will come about. But right now, it's really a visual perspective. But I'm going to show you some examples that the diagnosis was made on point-of-care ultrasound of aortic stenosis. And I give you several examples of that. And what should happen during systole, as you only see two leaflets of the aortic valve in this parasternal long axis view, but they should merge with the aortic wall. They should really almost blend completely with the aortic wall. And it becomes quite obvious when patients have significant aortic stenosis. So there's so much other stuff. I'm going to talk about LVH as well and how we diagnose that from the parasternal long axis. You can see here we got some papillary muscles. We can see the chordae. I'm going to give you a couple examples of some ruptured chordae and valvular heart disease. So there's so much things to look at. I think we start with the basics, start with the chambers, and then the ejection fraction, and then we move from there. Was there another question?
Yeah, Dr. Weissman, this is Shyam.
Please.
Question, the endomyocardial excursion, could you just explain that? I didn't quite understand.
Oh, absolutely. Endomyocardial excursion. Thank you. I'm going to go back to, so endomyocardial excursion basically means during systole, the cavity should come together, right? So that EF of 60% is obtained. So endomyocardial excursion implies that the cavity shrinks. So when I put my finger in this area, we're not going to see the apex obviously, but in this area, you should just about see the walls coming towards your finger. And again, this is an eyeball. If we were cardiologists, we would take a measurement of diastole and systole and we can calculate EF. In fact, the newer machines will actually do this for us, which is quite amazing. They'll actually calculate EF for us. But again, this are really all eyeball measurements. So again, the endomyocardial excursion refers to that shrinking of the LV cavity during systole. It should shrink by about 30%. I always say if I put my finger, if it's right here, it should be coming in towards my finger. Now, that's not a good example because it's really hard to see. And this hyperdynamic one, you can obviously, this endomyocardial excursion is collapsing. The whole cavity is being obliterated because all that EF in there, all that blood in there is being out because this heart's making up for a lot of bad things. So that's endomyocardial excursion. And then the myocardial thickening, of course, is actually looking at the actual walls, and they should thicken by 25%. As we go, I'm going to give you some more examples as well. Some of these don't show up as well as they should. Does that answer that question?
Yes, thank you.
Okay. Oh, you're welcome. This is M mode. M mode is an old form of ultrasound. It's still used in all vascular imaging, in echocardiography, as well as vascular imaging for the legs and such like that, and carotid artery. So basically we take a point where we draw a line, and we're going to see movement of structures along this line in real time. So here, this corresponds to the right ventricle wall here. This is the RV cavity here. Again, we're moving along this line. This is the septum. And then this up and down motion in the LV cavity, this black area is the anterior leaflet moving in the LV cavity. And this is the posterior wall. So this is where that E-point septal separation, why we call it E-point, because during passive filling, the first movement of the mitral valve is called the E wave. As we can see here, this is the E wave. The second contributor is the A wave when the atrium contracts during diastole. So what is amazing, and a lot of my pictures, you'll see the mitral valve actually flicks twice, right? It opens initially during diastole, and then it kicks again during the atrial contraction. Usually that's very subtle, and sometimes you have to slow it down to really see it, but it does, mitral valve does move twice during diastole. So here is that distance between the septum and the E wave. It should be on, very close to each other. This is normal. A patient with reduced LV function, it will be a far cry from coming close to each other. Again, 7 millimeters is considered normal. I always tell, use a centimeter. If there's a more than a centimeter distance here, you have reduced LV function. And the last example, the last sign we're going to see in the parasternal long axis is this example. This is a gentleman of mine who I'm a primary care doctor, as I mentioned. This was a 40-year-old patient I've been taking care of for years, always comes in with blood pressures 160 over 100. He is absolutely adamant against medications for blood pressure. I put the probe on his chest one day and got this picture just to run through the image. We have his left atrium here, his aorta, his RVOT, septum, here's his LV cavity, posterior wall, you can see the myocardial muscle here, papillary muscle, a little bit of the descending aorta. So I don't know if anything strikes you on this picture as concerning. One of the things I was worried about in this particular gentleman was his septum, and his septum appeared to me to be quite thickened. And certainly you can see, gosh, he's having complete collapse of his LV cavity. Left atrial size appears to be maintained. I mean, he's young still. He hasn't developed any left atrial enlargement as of yet, so that's a good thing. And so when we slow this down, we can actually, at the end of diastole, when the LV cavity is at its fullest, you can see when this valve is when the mitral valve is just about to close, that's when we're at the end of diastole, LV cavity is at its largest. We can measure the septum just about where the anterior leaflet would have hit it. Easy to do on all the devices, and you can actually get a measurement of the LV thickness. We measure the septum. Why? Because you can see the papillary muscle makes it very difficult to discern papillary muscle versus posterior wall. Septum's easy to do. It's very reproducible. And this gentleman had severe LVH. So we measure LVH by these measurements. Usually should be less than a centimeter in thickness. I know in our ACS, our heart failure floor at Union Memorial, the residents get quite used to seeing patients with 2-centimeter septums, and I my eyes always, jump open when I see that. Your differential starts getting, little concerning about patients with very thick LV walls. But this guy already had evidence of LV target organ damage, and by showing him this, I convinced him to go on blood pressure medicine, at least for a short period of time. So LVH, easy to do, well reproduced. Any questions on that measurement of left ventricular hypertrophy? We're going to move on to the short axis, and I hope I'm not losing anybody. But so we went from that long axis. Remember, we're looking at the 10 o'clock position with the probe marker to the patient's right, and this is now a 90-degree turn to the 2 o'clock position, the left shoulder. So again, we went from the right shoulder, 10 o'clock position, to the patient's left shoulder, the 2 o'clock position, which is the probe marker showing us going right there. And this is one of my favorite images in echocardiography, because you get this wonderful bird's eye view of the left ventricle. And this is the typical view you'll see when you make that turn. You see the LV, the RV, it looks like a crescent moon because it wraps right around the LV like this. We call it the crescent moon. Looks like a crescent moon. Anterior wall, lateral wall, posterior wall, inferior wall, septal wall. So, these can be broke up in further sections, but for our purposes, I only memorize 5 of the walls. And this is where the cardiologist is looking for evidence of regional wall motion abnormalities. And you can see these are 2 little bumps. These are the papillary muscles on both sides, the anterior lateral, posterior medial. And this is the vantage point where we determine overall ejection fraction in the short axis. And I was mentioning before, there's that tilt maneuver. So when you make that turn, typically you may be at the papillary muscle view, where it may look like this. You may be at the mitral valve view. I'm going to show you some videos in a minute. But I usually tilt towards the apex, looking at the apex first, and then I make my way towards the papillary muscle. So here's the apex. I'm tilting. and I tilt a little bit up towards the base, grab the papillary muscles, and then I tilt up toward the mitral valve. We call it the fish mouth. I'll show you why we call it a fish mouth in a minute. And then I tilt all the way to the base, slice open right through the aortic valve. And here we're actually peering right to the right ventricle here. We can see the left atrium. In fact, you can see a lot of things from this vantage point, even the pulmonic valve. So from one point, again, all we're doing is tilting in this one position. So that's why I plant myself down, and all I do is tilt the probe with my 3 fingers, my thumb, my index finger, and the middle finger, and I move the probe, and that is amazing how you can get to these 3 views. This is again, that papillary muscle view. How do you determine EF in this view? Well, there's a couple ways. And again, we're not talking about percentages. We're not the cardiologists. We're not going to be talking percentages. We're talking normal, mild, moderate, severe. Typically, again, all eyeballing, you should put your finger in the center of this, and all the walls should coursing around your finger, coming in equally well. This is a great vantage point looking for regional wall motion abnormalities. We only determine EF, overall ejection fraction, in this particular view at the papillary muscle view. So for the short axis, be very careful not to look at the apex, because you're going to overestimate EF. And likewise, you may underestimate it if you're at the mitral valve view. So we must be at the papillary muscle view. The papillary muscle should be kind of equidistant, and we should see all the walls equally well. The right ventricle is here. Again, the anterior lateral pap muscle, the posterior medial. And I would argue this is probably normal EF here. I'm looking at all the walls. Are all the walls thickening equally well? Are the walls coming in towards my finger equally well? And that looks to be the case. So again, I'm going to collaborate that with my other views. As we tilt the probe towards the base, we're going to see the mitral valve. This is why it's called the fish mouth. That should be opening by at least 1 centimeter. So if you're ever worried about mitral valve stenosis, you can see how well that mitral valve is opening up from this vantage point. And then at the base of the heart, this is one of my first residents who ever went out back in 2016, goodness, where you have the nice aortic valve pictured here. And you got that nice, beautiful Mercedes-Benz sign and tri-leaflet aortic valve. And we're peering into the right ventricle. We're high up in the base of the heart. So we are here. We're high up in the base of the heart. So we can see we're going right through the right ventricle, actually, to get to the aortic valve. And this is exactly what we're seeing. The left atrium is over here. But this is the tricuspid valve. And this patient actually had tricuspid valve endocarditis, interestingly. So very nice view. And in fact, all it requires is a rotation, a simple clockwise rotation to get to the pulmonic valve, which lives right over here. So that is the short axis in a nutshell. And I apologize, I'm going quickly, but I promise I'll bring it all together in the end when we do some cases, which I think will be fun to kind of go through to kind of reinforce what we learned. And the subcostal view. These are the 3 main views of the heart that I think every resident by the end of their first year should really know. You know, we've all been to M&M meetings, and there's probably I've been going to M&Ms as you guys have for eons. And always one of the top 10 diagnoses is that pericardial effusion that caused the patient to be in a shock-like state. And unfortunately, wasn't diagnosed. Either the CT scan was done or sadly post-mortem. So ruling out a pericardial effusion is easy when you have an ultrasound machine. It's not a guessing game. And I always tell residents, if you have a hypotensive patient, whether it's coming from the ER or coming from the floor to your unit, and you don't do a simple look at a subcostal view to make sure there's no pericardial effusion, I think you're doing a patient a disservice, because it is so important to simply rule out that one cause of shock, which could save your patient. So let's go through this, how we obtain this view. This is a bit different than the other 2 views. Remember in the parasternal, I don't know if you can see me, the long and short, we were holding it like a pencil or pen, and that's kind of, we're holding the probe straight up in the air, and it was pretty simple where we are. The subcostal view is a little different. We're going to hold the probe differently. Hopefully you can see this, what I'm showing you. And this is very important, the way you hold this probe. We have to come at a shallow angle in the subxiphoid space. And holding the probe in this angle, I don't know if I can get up, I don't know if you can see me, but you have to get into that subxiphoid space, and you have to be at a shallow angle because we're aiming up towards the heart. We're going through the liver. And you need that focal point of your index finger to really push down to get this good vantage point. So you get these nice, beautiful views. So again, it's different. The probe marker goes to the patient's left. Again, everything in echocardiography is pointing to the patient's left, except for parasternal long axis, which goes to the patient's right shoulder. Everything else points to the patient's left. So this will be the probe marker going to the patient's left. We're shining up through the liver. So that's why we always get a nice liver image. Remember, the right ventricle is always on top. So this is the RV, the LV cavity, the right atrium, LA. This is a great view if you can't get the 4-chamber to compare the ventricles side by side. You compare to the atrium side by side. You can certainly measure chamber sizes from here. A lot of things can be done from this subcostal vantage point, especially in our hyperventilated patients when you may not get anything in the chest because they're just so hyperventilated, have such large lungs that just can't get a good view. This may be your only vantage point. So typically you'll get a nice shot of the liver, you get the bright pericardium, the right ventricle, the left ventricle, the right atrium, the left atrium is down there. And that's a nice view. And this is, of course, what we're always looking for. This was a young patient who came in with a very large pericardial effusion. This is a subcostal view. Sorry about the quality of the image. I'm going to show you some more in the better views in a minute. This is the liver. This is the large, huge pericardial effusion. So the pericardium is somewhere up here. And this is between the pericardium and the heart. And this is a large, notice it's jet black pericardial effusion. This is the right ventricle. This is the right atrium. Just want to show you a few other videos on this. This is an important differential of pericardial effusion is the epicardial fat pad. So you'll see here the brightness in this area denotes the fat. And it's moving along with the heart. It was very different than that previous jet black appearance of that pericardial effusion. So this is the epicardial fat pad. So sometimes even I can get a little, sometimes it can be tricky. I will admit to that. Sometimes it can be a little tricky, but typically it's quite obvious if you have this brightness running through this area and it's actually moving along with the heart. Pericardial effusions can range in size. Epicardial fat pads are rarely bigger than a centimeter. And then there's the pleural effusions. The pleural effusions are on the left side of the body because we're on the left, can be also a little tricky. And this is where depth really helps us out. So here's the patient's descending aorta, and this is the pleural effusion of this patient. You'll notice pleural effusions get larger as we go deeper. And this is an example of a patient with a pericardial effusion and a pleural effusion. The pleural effusions are in the same plane as the aorta, but the pericardium and the aorta or the pericardial effusion is separated from the aorta, and it actually rides on top of it. So, right, so the aorta and the pericardial effusion are not in the same plane. So the pericardial effusion will cause what we call a rat tail sign. It'll wrap over top of the aorta and come out the other side. So it looks like a rat's tail. The pleural effusion will be in line. And how you know this, you're definitely gonna need depth. Depth is a friend. So if you're getting confused, and this happens to me sometimes, I'm not sure what is going on here, I go deep. And again, you may acquire a friend that has a little bit more skills in point of care ultrasound. If you see something anechoic structure, you're not sure if it's a pericardial effusion or not, go deep, and you can certainly scan the lung, which we'll talk about in a minute, to rule out the pleural effusion. But often the pericardial effusion by itself, very easy to tell. Again, here is that particular patient. This is in the parasternal long axis, and this is the subcostal view. This very anechoic fluid that is indicative of a very large pericardial effusion. Anything above a centimeter is very concerning. Of course, pericardial effusions can be worrisome, even if it's a smaller pericardial effusion. Another example of a patient. So now at this point, I always tell my residents, you see this in the middle of the night, your next call is to the cardiologist. It's really their job to determine if there's tamponade physiology. You can certainly do a pulsus paradoxus and see what is going on there. Tamponade physiology, a couple of clues was on echocardiography that can give you that information. So if there is diastolic collapse of the right ventricle, that's the most important sign. How do you know you're in diastole? When these valves are open, that is diastole. Here you really can't see when the valves are open. And if there is invagination of the right ventricular wall during diastole, that is always a concerning sign. Likewise, when the right atrium is at its fullest, right at the end of systole, and there's collapse of the right atrial wall. And sometimes when I see this jiggling of the right atrial wall, that's a concerning sign. You can see it kind of here too. This kind of jiggling motion of the right atrial wall and certainly the right ventricle as well. So again, we're looking for diastolic collapse of the right ventricle as the most significant sign, the end systolic collapse of the right atrium. And then we also may look at the IVC. And because these chambers are not able to fill, you will see no movement or inter-respiratory variation of the IVC. So just some things to keep in mind. But obviously, I always tell residents, if you can see like this is a much smaller pericardial effusion, but it looks like it's causing some compromise to this patient as well. And any questions on that? Again, I want to get to the ending where we kind of bring it together with some cases and keep in mind the time we have. We're going to move to the IVC because it just lends itself so nicely when you're in that subcostal view of the heart, just to simply look at the IVC. So if you can see me, I don't know if you can see me or not, but if you can, what I simply do is I'm measuring the IVC, I gear in on my right atrium. This is always better if you have a real SP with you, but you gear on that right atrium and I just keep my focus on there and I concentrate on there and I'm turning my probe counterclockwise with a probe marker to the head. And that's how I obtain the IVC. There's a lot of different techniques of obtaining the IVC. Mostly to measure the IVC, you have to be directly parallel on top of it. Typically you get that view of the right atrium, the IVC, hepatic vein coming down. And we measure the IVC just distal to the hepatic vein. That's very important that we be consistent where we measure the IVC, and we measure it just distal to the hepatic vein right here. The problem, there's a lot of problems with the IVC. It is by no means a holy grail for volume assessment. It is riddled with problems, and we'll talk about a little bit about that. And why, one of the reasons it's riddled with problems, if you tend to cut it short, there's no fancy, unfortunately, AI yet that can tell us you're off axis with the IVC. You need to be more centered. But a way I do this to make sure I am centered, it's simply a matter of sweeping the probe back and forth over the IVC. I don't know if you can see my finger, sweeping the probe over and forth over the IVC, looking for my largest diameter with my thickest walls. So I want to see the largest diameter, and typically that's when the walls are the thickest. And that's typically, that you're on axis with the IVC. You're measuring the true diameter of it. As you know, there's respiratory variation with the IVC. When we take a breath in, it decreases intrathoracic pressure, draws blood from the IVC into the right atrium, and that will collapse the IVC. So here's kind of what we typically will see. I'd like to see this nice view of the right atrium. The IVC is here, the hepatic vein is here, and I'm measuring the IVC motion here. I'll just measure it straight out. There's not a whole lot of respiratory variation in this particular IVC. I can't remember the issue with this patient. Everything, of course, in ultrasound is taken in context in the clinical picture, what's going on with the patient. And we measure the IVC. Remember, I mentioned that 2 centimeters is the magic thing for vascular structures, and so too is the IVC. So a normal IVC is about 2 centimeters. When it's less than 1.5 centimeters, we tend to think of patient very dry. And there's an example of a patient who's got a collapsible IVC. This patient came in, metastatic colon cancer, dehydrated. We didn't need the IVC to tell us he was dehydrated, but this is what it looks like. I look at the hepatic veins. They can be very informative. When the patients are very thin very thin hepatic veins, that also gives me another clue. The IVC tends to be very useful at the extremes. So when it's very collapsible or very collapsed, or when it's very juicy, this is about 3 centimeter IVC in a patient with heart failure. Anything above 2.5, big juicy IVC. So as I often say, the cardiologists tend to love the IVC, the intensivists tend to not rely on it. And I'm going to give you an example why that is. So this middle example, I'm going to show you here. This is a patient in the ICU who's septic from a bacterial infection. The patient's on multiple vasopressors. And you look at the IVC and your attending asks you, would this patient benefit from a bolus of fluids based on what you're seeing from the IVC here. So again, this patient's on pressors, they're very sick. You can kind of see what the heart is doing. It's very mobile, it's hyperdynamic actually. So it's off its Starling curve. It's aggressively pulling blood from the IVC and filling itself up. And so you may make the assessment that this patient's intravascularly depleted based on what you think may be some collapse of the IVC, but that would be an incorrect interpretation only because the heart is off its Starling curve, hyperdynamic, doing what it can to keep the organism alive, this patient alive, and in doing so, unfortunately, is collapsing the IVC. So this would be a false interpretation of their intravascular volume. So the nice thing about looking at the IVC through ultrasound, it's dynamic. You can certainly give the patient, a bolus of fluids, 500, and then see what happens to the patient. But better than that, the cardiologists do rely on it often when you're diuresing patients to go back to the IVC and see how we're doing. They often like to look at JVP, but sometimes having a look at the IVC is very helpful. We do talk about percentage collapse, and I think this is too problematic to rely on. So we say when there's over 50% collapse of the IVC, the patient may be on the dry side. Normally, it should be less than 50% collapse. Again, that's an eyeball figure, but we call it the sniff test. So if you artificially sniff, you can collapse. Trust me, I can sniff hard enough to collapse my IVC, and I'm probably not intravascularly volume depleted. So that's why I'm very careful with this assessment of percentage collapse. I think at the extremes, IVC is helpful for you. In between, I'd be very careful. And if we're looking at that patient with volume responsive hypotension, the IVC is probably not your best answer. So here is the confidence interval for a positive test for likelihood ratio that's positive on volume responsive hypotension, just utilizing IVC. The confidence intervals are very wide, from 1 to 27. This is patient on controlled ventilation even. And you can see here that it's just too wide of confidence intervals to be a reliable test. Your better test is passive straight legs raise and measuring cardiac output before and after, or mean arterial pressure before and after. If you can measure cardiac output after straight leg raise, that is your best assessment for volume responsive hypotension. So in the ICU, the intensivists know this, and they would tend not to rely on the IVC because it is riddled with problems, but the cardiologists do like it. All right, any questions on IVC? We're going to enter the last segment on quick one on lung, and then we're going to come together with a few cases, and then that'll be it. And then we'll give you some useful sites to check out. So this last part is the lung ultrasound, and lung ultrasound is huge. We could be here with Gigi Liu giving us a 2-hour lecture on lung ultrasound, or maybe half a day on lung ultrasound. This is a very quick examples of lung ultrasound. It is extremely helpful, but we're going to think about 2 questions to answer. One is the patient full of fluid. Do they have pulmonary edema everywhere? Is the lung now a wet sponge? Question number 1. And 2, does the patient have a pleural effusion? We're only going to answer 2 questions primarily with our discussion today, but trust me, there is a multitude of questions that can be answered with lung ultrasound. So this is typically what we have here. How do we do lung ultrasound? If you can see me, we will straddle the ribs. So the ribs are running horizontal. I am perpendicular to the rib, and this is very important. Probe marker goes to the head. So remember, straddle the ribs perpendicularly with the probe marker to the head. And you'll notice there's 4 segments. I mean, there's, of course, segments posteriorly as well. Most of our patients tend to lie supine. If you have an outpatient, you can certainly get to the posterior compartment. The biggest problem with lung ultrasound there is, unfortunately, no agreement on what is the right protocol. And that is the big downfall of lung ultrasound. Hopefully that will be eventually agreed upon, and we'll all be doing the same thing. For now, it's kind of a lot of different protocols out there. Which one do you follow depends upon what do you do in clinical practice. But I tend to break the lung into 4 sections in the anterior and lateral components here on both sides. So it's 8 sections in total. And basically I'm putting the probe in each one of those areas. So I'm doing the anterior sections, and then I come down to the gutters, do the gutters of the lung, and then move up laterally and come up from the inferior, go superior. And what you'll see here are rib shadows. We call it the bat wing deformity. We have shadows here from ribs, and in here is what lies the lung. Now, of course, the lung is a structure full of air, and we thought at one point, how useful could ultrasound be? Well, it turns out to be quite useful. So here we have the rib shadows. Here is the lung, and they have the very bright pleura. And the pleura is a highly reflective surface. Now, it's not like bone. Will block all ultrasound beams from going through. So some ultrasound beams do penetrate through the pleura. Often they'll go back up, and it creates this ping pong effect. And this ping-ponging of ultrasound beams creates this visualization of A lines. We call these horizontal reverberation artifacts of the lung A lines, and they're horizontal, they're straight across. This is anybody with normal lungs would have a pattern that looks just like this. And they measure out perfectly. This is the skin surface. So here I'm at the skin with the probe, and from the skin to the pleura is this distance, which it looks like about 2 centimeters down. And every 2 centimeters, we see an A line. And this is, everybody's a little different depending what the distance is from the skin to the pleura, but that should march out perfectly well. With our rib shadows here, you put the probe on. Sometimes people have problems getting those A lines to come out, and I love teaching how to get those to come out because it's not hard. Remember, you have to be perpendicular with that pleura to get it to come out. So you have to often rock the probe to get those A lines to come out. So you can't tell exactly if you're perpendicular what lies beneath the skin. So you rock the probe and then douse. This is one area I dice down the gain very low. So often I do all my scanning in cardiac mode. I just leave it there. It's easier. But cardiac mode, remember, as it starts at a very high frequency, very bright. So I dice down the gain to make it dark. That'll really bring out these A lines. So that's a few little pointers to help bring out those A lines. And this is the main pathology we're looking for, called B lines. When the lung is saturated like a wet sponge and full of fluid, when the ultrasound beams hit it, we get these reverberation artifacts now called B lines. And they're vertical lines that stem right from the pleura to the bottom of the screen. Patients can have 1 or 2 of these and it's considered normal. 3, 4 or more is abnormal. So this patient has a whole lot of ultrasound beams. Oops. Let's see if we can play that again. So that's what we're looking for. They almost are so common or so dominant, they knock out the A lines. So again, they stem from the pleura all the way to the bottom of the screen. And if you see this at multiple of those 4, all those 8 lung locations, well, nothing else does that but pulmonary edema. So that is a wonderful way to look for pulmonary edema. So if you have B lines everywhere you look, that patient has pulmonary edema. You can see the likelihood ratios here are off the chart. And I know a lot of intensivists actually just rely on lung ultrasound to know when their patient has well diuresed, and cardiologists are getting there too with looking at lung ultrasound to determine when the patient is in fact diuresed well. What will happen over time, these B lines will disappear and the A lines will reemerge. And at the gutters, I'm looking for pleural effusion. So I always start at the gutters. And when I mean I'm at the gutters, I don't know if you can see me, my probe is down towards my costophrenic angle, just below my rib line. I tend to keep my fingers towards the patient's bed, so they're actually touching it, because I tend to like to look at the kidney here too, but we're not going to talk about that right now. And from this vantage point, I'm looking at the liver, if I'm on the right side, the diaphragm, and here we have the lung, and in that lung space, that pleural space is a big effusion. And this is a transudate, completely dark, and ultrasound is very good at determining the difference between transudates and exudates just by looking at the fluid. Exudates will typically have this, what we call plankton sign, this floating debris that's floating around in the fluid. It is not completely anechoic in jet black as it is in a transudate. So it's a very effective way for looking at effusions to compare. So if you have a heart failure patient who has a large pleural effusion, if they don't need a tap, if they don't symptomatically need it, well, there's no reason to tap that patient, because you're probably not going to find much here other than a transudate. But if you see something like this in the context of pneumonia, you're probably going to be tapping that. And here you can see the lung gets squished with a whole lot of fluid now that comes around the lung. We call that hepatization of the lung. And now you can actually visualize lung structures. So pleural effusions are so easy for ultrasound to pick up. It's so exquisitely sensitive. It can pick up literally milliliters of fluid in that pleural space. This is a wonderful sign called the spine sign. I use it all the time. So this is this. So if I'm on, again, that coronal shot, looking at just below the costophrenic line, I'm looking at the spine here as it comes in contact with the diaphragm, which is here around the liver. And you should not see the spine once we get into lung territory. Why? Because you get all that air, it dispels all those ultrasound beams. You're not going to see the spine anymore. So you lose the spine after the diaphragm. But if you have fluid in this space, remember, ultrasound beams love fluid. They'll swim and they'll hit the next solid structure, which is the spine in the midline. And then we see the spine coming out. And this is called spine sign. So you can pick up just literally 10 milliliters of fluid in that pleural space. It's just incredibly sensitive for pleural effusions. And this is a very helpful sign I use all the time. if I'm worried about something living in this space, whether it's fluid or empyema or mass, whatever, I have the patient take a deep breath and the lung comes in and knocks out the diaphragm. It just obscures it out of the way. That's called curtain sign. If it's able to do that, there's nothing living in this space down here. If the lung is not able to come down and wipe out the diaphragm as it's doing here, then something is in that subpleural space. Don't know what it is, but something is living in that subpleural space. So it can be very helpful to reconfirm if there's any fluid in that space. Briefly, this guy, Dr. Kamiru, put these components together into what's called the clue exam. It's a cardiac lung ultrasound exam, a very focused exam, and I can give you the literature. In fact, I'll give it to Mary Ellen, this literature reference, and basically utilizing these areas we talked about today. We talked about every one of these points, and this is very helpful for resident training. You basically isolate these 7 points to look at, and based on your findings at these 7 points, you put them into his table, and you'll basically diagnose most patients that come in with complaint of shortness of breath. And that'll help at an adjunct to ultrasound. I always tell residents, do not just rely, please, on your ultrasound. This is all taken in context. And if you're good at it, you can literally get this done within less than 5 minutes. Literally, you can get all these 7 points done within less than 5 minutes with practice. So it doesn't add a whole lot to your current exam. Now we're going to just go through a few interesting 6 cases. I think that may help put it together for us in ultrasound. We'll do a little bit of the clinical context, but we'll mainly just show ultrasound images. So this first case is an 85-year-old man who comes in with shortness of breath and new onset AFib. So we'll take a look here at this patient's parasternal long axis on the left, and this is the patient's short axis, and then this is the patient's lung. All right, how about we start with the easy one? What do you guys think of the lung?
Edema?
Yeah, that's pulmonary edema, right? Exactly. We got B lines stretching on down from the pleura. And let's say this patient had B lines everywhere. By the way, when you look at those 4, each side, we have the 4 areas of the lung. We describe A or B lines in those areas. For example, if the patient comes in with short of breath and the history compatible with pneumonia, often you'll get B lines isolated to one area of the lung if it extends to the pleura. Pulmonary infarcts will do the same thing. When the lung is full of any fluid, whether it's pus, blood, pulmonary edema, it'll look the same. It'll look like B lines. By the way, as we get more sophisticated, we tend to look, our eye gets good at looking at the pleura. And as you've probably seen the literature on, with COVID-19 especially, it creates a very abnormal looking pleural surface. So does too is interstitial lung disease. So if you tend to get a pattern that looks half A, half B, a mixture of both, and your pleura is all ratted up, meaning there's beads, and there's thinning, and there's beads of pleura, thickening of the pleura, and thinning of the pleura, thickening of the pleura, that is indicative of interstitial lung disease. Interesting, COVID-19 does something very similar. So some things kind of overlap in their presentation. But anyway, absolutely, this patient had pulmonary edema everywhere. How about that? Let's look at the long axis here.
Short axis doesn't look good.
No, right, short axis is, so right, I should put my finger in here, and those walls should be coming towards my finger. And that, it's amazing how patients stay alive. This patient, right, had a severely low ejection fraction. Let's take a look at that long axis. Again, here's that edge artifact. It tends to be more common than we think. So here's the left atrial wall, 1, 2, 3, 4 centimeter left atrium. I don't see a whole lot of aorta here. Probably I would have moved a little bit to brushing that up. Even the right ventricular outflow looks generous, about 3 centimeters, maybe more. This is, endomyocardial thickening, not really. When you start seeing a lot of darkness in the myocardium, it's probably from scar tissue. Patient had probably a previous ischemic injury. Endomyocardial excursion, well, not much happening here. I put my finger right here and nothing's coming through. And that my E-point septal separation, not much. You guys have the descending aorta there. So this is example of a patient with a severely low ejection fraction, severely low heart failure with reduced ejection fraction that would be severe with pulmonary edema. This is a 67-year-old female with end-stage renal disease on peritoneal dialysis, comes in with shortness of breath. Let's play these images here. Some of these, I think this is the 4-chamber view I didn't review today. Oops. I'll get that one to play in a minute. I got to turn these off first. But let's look at this patient's short axis here. So again, I should put my finger in the middle. It should come to my finger. And after you get looking at a lot of these, you may say, well, that may be slightly reduced, maybe slightly reduced. Not a great image. And that's what happens in real life. Unfortunately, images are not always good. This is the 4-chamber view with the left atrium, the left ventricle, the right atrium. Here's that anterior leaflet. And usually you should see it come towards the septum a little better than this. Not a great shot either here because I'm missing the lateral wall. But this lady had an ejection fraction about 40%. So this was mildly reduced. And this is the important shot here, the subcostal image.
Is that pericardial effusion?
Yeah, absolutely, absolutely. Even though it's, it's not the best image here in the world, but you have the left ventricle, the right ventricle, and now we have a nice pericardial effusion. So this lady had peritoneal dialysis, developed a uremic pericardial effusion. She was been underdialyzed at home, and this one I'd like to show you if I can get it to play. Let's see. There it goes. So this is interesting. So this is the patient's pleura on the right side. So again, I'm on that costophrenic angle on the right side. We can see the movement of the lung, and here's the diaphragm moving, the liver, and in this pleural space is a nice transudate of fluid. And that's not an alien in her chest. That's actually the lung. And that's atelectatic lung just flipping around in that fluid. So it looks like a bird's beak or something just flipping around in that lung. So the question often comes up, well, how do you know that's not consolidated lung versus atelectatic lung? And that's a little level 2 question, but it's a good question. We talk about, you can certainly see air bronchograms in ultrasound. They'll be more indicative of pneumonia. And that, we can talk about that later. How do you look for air bronchograms on ultrasound? But that is a good example of atelectasis and what happens with a lot of fluid. So this lady was basically full of fluid and basically needed hemodialysis for a little bit to get her volume status a little straightened out. This is a 84-year-old lady with cor pulmonale, valvular heart disease, presents with increasing abdominal distension. There's a lot of images here. Let's take them one at a time. This is the patient's parasternal long axis. Parasternal long axis. And let's measure, this lady is about a 90-pound, if that, year-old little lady. Her left atrial size, 1, 2, 3, 4, 5.
Dilated.
Yeah, very dilated left atrium. Here's aorta, 1, 2, aorta maybe a little generous. RVOT also looks a little generous, 1, 2, 3 maybe.
Hyperdynamic.
Yeah, hyperdynamic, exactly. The cavity is almost completely obliterated. Very thick walls. Look at that we can measure that septum, but just eyeballing it here from these centimeter markings, it looks at least 2 centimeters. And you see this thing flipping around in her cavity, and that turns out to be a ruptured chordae tendidae. So she had valvular heart disease, previous damage. So she had actually severe mitral regurgitation, which wouldn't be hard to put some color flow in here and determine that. But this poor lady had severe MR. Look at this small cavity she's working with. I don't know if anybody noticed. What do you think of the aortic valve?
No.
Right. Well, it's a good question about bicuspid. So we only see 2 leaflets in the trans and long axis of the heart. So we can't comment necessarily, but you can kind of make an assessment on it's a good question you brought up. We need 2 leaflets that we can see of the 3-leaflet valve come together. They should come together dead center in the aorta, just like they are here. So if they tend to come to one side together or the other side, that's a good indication you may have a bicuspid valve. And of course, this is not the best view for bicuspid valve. We're probably we're gonna look at another view, which may be the short axis. But it looks stenotic, right? I think someone said that. So if you had to measure the opening of these valves, that looks awfully tight. And she had just over a centimeter aortic valve opening here. So although we don't have spectrodoppler to measure this velocity through here to tell us what the velocity is that we'll get a regular echo for, but certainly, you don't need spectrodoppler necessarily to tell you this lady's got, there's probably some significant aortic stenosis here. This was her IVC. And sorry about that, not a great image. Looks a little generous in that IVC. And I'm going to show you this. This is a very important short axis. Now, this looks a little different. This is I use my V. I use my. You can see the difference between the V-Scan and the Lumify. For the one program in Anne Arundel, they made a great decision to going with the Lumify. It's really such a great handheld device. So this is just, it's a much clearer picture, as you can see. And that's just showing the differences in the devices. But this is a short axis. What strikes you on that short axis? Look at that right ventricle.
Is there diastolic collapse?
Yeah, right. So you're of the LV cavity.
Yeah.
So what we notice here is the right ventricle is massive. Now, the best way to look for right ventricular size is really in that 4-chamber view, which we didn't see today. But this is such an important point here. Remember, in the short axis, you should have a perfect O, the perfect round O. It should be a beautiful O. This is not a beautiful round O. This is, if you turn your head just slightly to the 9 o'clock position, you can see this looks like a D more than an O. And this is called the D sign. And this basically tells you that the right ventriculum is over volumed and paradoxically pushing that septum the other way. So the poor left ventricle is not only dealing with a very small cavity from long-standing, probably hypertension, or maybe she's got some other disease causing left ventricular hypertrophy. She's got valvular heart disease to contend with. And in addition to that, she's got this right ventricle that is paradoxically moving the septum the wrong way. During the cardiac cycle, and that's causing that D sign. So that D sign is always a concern of right ventricular overload. If it happens acutely, you may be thinking about pulmonary embolism or some other cause of right ventricular failure acutely. But that's a good thing to keep in mind, that D sign.
So for this patient, you would diurese?
Well, it's a good question. Depends on her symptomatology. Here's her abdominal distension. You can see her liver and her small bowel. She's full of ascites. So yeah, exactly. So diuresis was part of her treatment regimen. And essentially, unless you can fix the valves, which, you know, she was, probably a little old to probably consider that, maybe the aortic valve, but she definitely didn't want any more intervention done. So exactly. So we didn't have too many treatment options for us other than diuresis. Exactly. So that is case 3. We got a few more to go through. This is an interesting one. A 50-year-old guy, I'll give you this history. He comes in with a history of pulmonary embolism that he had 5 years ago. So he came in again short of breath to the ER. And of course, they did a CT angiogram, a CTPA of the heart, a CTPA of the lungs, and found that he had pulmonary embolism again. They admitted him to the med floor. And we came in the next day and did this scan. Now, he's a 350-pound guy, so it's a really bad image here. That's his IVC. It's dilated. I'm going to shut that off. These are 2 4-chamber views of the heart. Now, granted, again, the little V-scan with the 350-pounder is kind of pushing the V-scan to its limits. But this is his LV, and you can see this is the right ventricle. And this right ventricle, I can't even catch the wall of the RV here. It's so enlarged. This is a particular sign that's good to be aware of called McConnell sign. So McConnell sign is when, what's amazing is the RV can expand in size within 24 to 48 hours. So when it gets overloaded, it can get huge. The LV cannot do that within that short period of time. So it accommodates, but once it gets this big, it just can't do anything. It basically gives up. The only thing that moves at this point is the apex of the right ventricle. And you get this hinge sign. So it looks like a little hinge. I don't know if you can kind of appreciate that. It's called the hinge sign, McConnell sign, indicative of impending RV failure. And although PE is not the only thing that can do it, it is a very worrisome sign in pulmonary embolism. So here we came in the morning, the patient was just on a med surg bed, and we saw this, and this makes your hair in the back of your neck stand up a little bit. He is in not a good spot, so we quickly moved him to the ICU. And later, he did end up getting catheter-directed therapy with thrombolytics for his PE. At the same time, or later that day. So the McConnell sign is good to keep in mind. This is another example. This is a nice example of the 4-chamber view. Again, you can see the LV and the RV, the difference in sizes. The RV should be 2/3 the size of the LV. It's a very large right ventricle, and the only thing that is moving is the apex of the right ventricle. Again, that is McConnell sign. So you see that in the echo report, that's always worrisome. All right, 2 more cases, and then we'll be wrapped up. This is an interesting lady. Sorry for so many cases here, but this is a 100-year-old lady we saw on the consulting service from orthopedics. She came in with a hip fracture, and 3 days after hip fracture, she was short of breath. And so they consulted us because of that shortness of breath. And she also was like maybe an 85-pound little lady sitting in bed, short of breath. Again, 3 days after total hip replacement for hip fracture. And we'll start with the lung here. Here's the pleura, and you can see some what we call lung sliding. And I didn't talk about this, but this is when the visceral and the parietal surfaces slide over each other in a little millimeter of fluid. They slide over each other back and forth, really cool. And you can see her A lines pretty clearly. If I move my cursor, A lines are clear. So no pulmonary edema. All right, so we ruled out pulmonary edema as a cause of her shortness of breath. Kind of working backwards a little bit. Her IVC is enlarged. Keep that in mind. Here's a short axis. I don't know if it helps us much, but it looks like to be a hyperdynamic. Heart's moving. It's not a great shot. I'm going to turn these off for a minute. Let's concentrate on the very dark parasternal long axis. And here's a look at that.
Massive left atrium.
Massive, right? Absolutely. Massive. So we know this lady's had long-standing probably diastolic compliance issues. Again, similar to the other lady, thick LV, small cavity. We even see some calcifications around this mitral valve here. And again, key your eye onto the, what do you think of that aortic valve again?
Stenosis.
Yeah, this lady had a 0.6 or 7 areostenosis. Her gradient was extremely high. And what scares, what's amazing to me is, right, this lady already had her surgery. She's 3 days out. When you're an anesthesiologist, a couple things, worry you before surgery. And one of them is aortic stenosis. They don't like not knowing about severe aortic stenosis because patients can often crump during surgery. And this lady had severe AS undiagnosed prior to surgery. She survived the surgery, but what happened is in her post-op days, she developed atrial fibrillation, which was new to her, which you obviously can't tell here. So she was in AFib with RVR, and on top of that had severe aortic stenosis. So she just was no longer able to compensate. And that was ultimately ended up being the cause of her shortness of breath. But yeah, again, we probably should have picked up the very loud murmur on the exam. But amazingly, you can see she got through surgery and got through an anesthesiologist assessment and didn't have the diagnosis. Interesting. I have one final case that this is a gentleman who came and saw me about a month ago now in the clinics. I am a primary care doctor. He's a 93-year-old gentleman I've been taking care of for many years of polycythemia vera, healthy as a horse otherwise, other than macular degeneration, sadly. And he's unfortunately legally blind because of macular degeneration. But other than that, he's got polycythemia. He refused hydroxyurea for years, so he's been on intermittent phlebotomy, which he does happily, and he's done well for a long time. And as that generation of 93-year-olds go, he came in to see me as a routine visit, complaining of a little shortness of breath, he said. He can no longer do his neighborhood walks, progressively got shorter of breath, and he was, I had to squeeze it out of him to tell me. And he had leg swelling, but that wasn't even part of his complaint, although he had 3+ pitting edema of his legs. He was a very, in addition, he's got kyphoscoliosis, very difficult to examine his neck because of his spine disease. It's just, he cannot open his neck area. Heart exam was fairly unremarkable, to be quite honest with you. He did have decreased breath sounds bilaterally, and again, this 3+ pitting edema was seen. So of course, my first thought was, okay, he's got heart failure now. So I put the probe on his chest, and this is the subcostal view. So I was a little shocked to see this finding. So just the main structures, we have the left ventricle, the right atrium, the left atrium. And I don't know if you can appreciate that very large pericardial effusion there. 2-centimeter pericardial effusion. And this is in his short axis. And you can see his heart just kind of jostling around in the fluid. And you can see why patients get this electrical alternans because of that movement in the sac, that heart just kind of free flowing in there. In addition, he had this big pleural effusion on the right. So that was the decreased breath sounds were because of large pleural effusions. This is on the right side. And interestingly, on the left side, he had a massive spleen, which is no surprise really, although I could not detect that on my exam. But it was actually, this is his spleen, huge spleen, seen on ultrasound for his polycythemia. So I called the cardiologist that day. We admitted him to the hospital. He was has pericardial centesis the following day with a drained over 500 serosanguinous amount of fluid. And then I got a call from the pathologist about a few weeks later that they were suspicious he had the B-cell lymphoma. So it turned out to be B-cell lymphoma as the cause of his pericardial fusion. Unfortunately, that diagnosed by pericardial centesis. How about that? That is a crazy story. But he's been getting rituximab, and given his age, they didn't do the whole typical chemo regimen, but rituximab, he's doing quite well. So there's several references out there. If you guys are interested in point of care ultrasound, I highly recommend this textbook as a must-have. This is the standard by Dr. Tony. And this has wonderful videos that you'll be able to access on your phone. This is a must-have. Society of Ultrasound and Medical Education. I have a curriculum I give to residents. I have a lot of other links. There's 5-minute ultrasound, which is very popular, where you see these 5-minute clips on various topics in ultrasound, which are very helpful as well. And that is the end. I'd be happy to answer any questions, and I appreciate you guys sticking around this long because
Thank you. It was very, very instructive.
Oh, thank you. Thank you. I appreciate that greatly. Thank you. I didn't know how, everybody's different in what level they're at, and you try to cater towards everybody. And
it's got my interest. I'm going to.
That does my heart good. I feel like my mission was accomplished.
You have. Thank you.
Absolutely.
Thank you very much.
Oh, you're welcome, guys. You're welcome.
Thank you very much, Dr.
Thank
Weidman.
you. Thank you, Dr.
Thank you.